As I mentioned, I'm Maryam Lustberg, one of the breast medical oncologists at Yale, and this is not going to be me lecturing at you. Really, the idea will be that there'll be lots of time for questions. So feel free to interrupt me at any point, and there are not that many slides. So if needed, happy to kind of as we talk, feel free to shout out anything that does not make sense to you. So recurring theme that you will continue to hear today is breast cancer. Each subtype has its own flavor and variety. So as you can see, you're in the most common. Luminal A or luminal B is the official kind of terms that we use scientifically for these hormonally receptor positive tumors. And this is basic biology. It's more intricate than this, but the idea is that estrogen receptors are places on the tumor where the main female hormone estrogen fits, and it starts a whole cascade of events that activates these cells to grow. And so this is part of the biology of your type of breast cancer. I know you're not in the HER2 positive group, but the HER2 positive story is going to be particularly relevant for your type of breast cancer in that we think of the HER2 as these growth antennas that sit on top of tumor cells. We used to think that for it to matter, you had to have a lot of these signals. But as the story has evolved through dedicated research, as you'll hear about, just having a little bit of that HER2 signal in the setting of hormone receptor positive breast cancer, we now have very specific drugs that go after this, a little bit of HER2 signal. So that's why I'm mentioning it for this type of breast cancer. So this is the HER2 low story that you may or may not have heard about. If you don't know your HER2 status, we're gonna kind of talk about just where to find it in your pathology reports. You can also certainly ask your oncologist, but about 63% of patients with hormone receptor breast cancer have a little bit of that HER2 signal, classifying them as HER2 low. The other important takeaway is that that little bit of HER2 signal could happen in any of your tissues. So even if you had a breast biopsy maybe 20 years ago and that showed a little bit of HER2 low signal, it still matters. So that just a little bit of that HER2 signal in any of your tumor tissue qualifies you for our HER2 directed therapies that I will cover in a second. So this is what a typical pathology report looks like. So if you're interested and you're not overwhelmed by looking at pathology reports, I think it's a good tool to take to your oncologist and make sure you know your latest pathology report. I always encourage my patients to be asking questions about their pathology report, and it really enriches the conversation. And it's your right. This is your body, your health information. So kind of as you look at your pathology reports, any breast tumor tissue will have information on that estrogen receptor positivity. And then you typically see a percentage associated with it. That's simply saying, if I take 100 tumor cells, how many of them have that stronger estrogen receptor signal? So in this particular tumor biopsy, essentially almost all the tumor cells are driven by this estrogen pattern, estrogen receptor pathway. Then you'll see PR or progesterone receptor positivity. This may be positive or negative. So as long as you're estrogen receptor positive, the PR could be positive or negative. Regardless, you would still classify as a hormone receptor positive breast cancer. And then you'll have a measurement of your HER2 new signal. In this particular biopsy is 0, but it may say something like 1+ or 2+, and that would be a more HER2 low tumor. And then it may have additional biomarkers that you can always discuss with your oncologist, but this is like a basic pathology report. So there's been as you heard, lots of advances in how we treat hormone receptor positive breast cancer. And this is kind of when I started out as an attending in 2010. So this is how much things have evolved. Essentially, patients with metastatic HER2 positive breast cancer, what I would offer my patients was single agent endocrine therapy and estrogen blocking therapy. And once they progressed, I would switch around their endocrine therapy to another pill or an injection. There were no targeted therapies at the time. And if things were rapidly progressing, all we had was plain traditional chemotherapy. So things are very different now. As you can see, lots of advances as you've heard about. And one of our biggest advances has been the approval of these targeted therapies to help the endocrine therapy work better. They're never taking the place of endocrine therapy or estrogen blocking therapy. But what they do is they help the tumor cells slow down a little bit more so the estrogen blocking therapy can work a little bit better. Busy slides, but we're going to cover a lot of these in discussion today. But the idea is that we have a number of targeted therapies on top for hormone receptor positive breast cancer. We still use chemotherapy, so chemotherapy is not out of the picture. It's one of our tools. But what has happened is that it tends to be coming much later in time because we have a lot more newer drugs. And we also have a newer way of delivering chemotherapy that I will talk about, known as antibody drug conjugate. Just hold that thought. I'll come back to that and explain it. And then that last box is also really important. If you have not had genetic testing, it's really important to talk to your oncologist about that. Even if you have zero family history, in the setting of metastatic breast cancer, we have 2 approved drugs for patients who have genetic alterations. And so that's information that we do not want you to miss out on. So if you have not seen a genetic counselor, have not had genetic testing, it's an easy blood test to do, and it directly can impact your care. Most often it's still going to be negative, as majority of patients with metastatic breast cancer do not have an identifiable genetic pattern that's passed down through families. However, it's important information to have. And then you're also going to hear the story that we are also testing the tumor quite a bit. This is separate from you. We're interrogating our tumors a lot more these days to find what drives them. So that's another piece of information that I'll talk about. So if you've been treated for metastatic breast cancer in that first line setting, you likely have heard of these CDK4/6 inhibitors. Not going to spend too much on them, too much time on them, but the idea is that they're kind of like brakes on the, they're the brakes. So they sort of slow down the tumor growth so the estrogen blocking therapy can work better. The brand names for recognition are things like Verzenio, Kisqali, Ibrance. And so see them as key partners to the estrogen blocking therapies. They're not in place of, but they help things, help the treatment work better. As you likely have experienced, they work quite well, but they can be associated with various side effects that generally we can manage through our partnership. So when patients report side effects, there are things we can do, including potentially reducing the dose of that drug, and that can help it be more manageable. So for both Kisqali and Ibrance, we watch for white count issues or neutropenia. For Kisqali, we watch this interval on your heart monitor called QT. Diarrhea can happen with Verzenio. All of them can be rarely associated with lung inflammation in less than 1% of patients, but this is why your doctor will ask you about, are you having any shortness of breath or cough? So what we'll spend the most time talking about is what happens after patients progress on these first-line CDK4/6 inhibitors. And this typically, you're not an average, you're a unique individual and your experience will be different. But on average, patients on first-line endocrine therapy, targeted therapy with CDK4/6 inhibitors stay on it about 2 years before needing a change. Now, for some patients, it will be shorter. For some patients, it will be many years longer. It's quite a range. But after that, the most important takeaway for you is that we need to understand the biology of your tumor. So it's really important to, at that point, after that first line, to either have a repeat tissue biopsy or even a blood test known as a circulating tumor DNA that will tell us what additional targets are on the tumor. And we'll talk about some of these targets coming up because we actually have specific drugs that target these pathways. Now, there are times where we do this type of testing and there is no specific target. In those cases, we do have some data that doing another CDK4/6 inhibitor in sequence can also give you some benefit. But most patients will have something to target here. And I think this is the second most important takeaway from this talk, is to kind of know the genetics of your tumor. So I will talk a little bit about changes in the estrogen receptor. We talked about how for your type of breast cancer, there's a lot of places where these estrogen receptors are present. And what we have done is we've put you in a very low estrogen state and kind of block the activity of these receptors. But these tumors can be smarter than we sometimes want, and they sort of learn tricks to go beyond that low estrogen state, and they acquire changes where they don't care that the estrogen levels are low. They find newer ways to grow, and that change is known as an estrogen receptor 1 mutation. And as you can see in the plot, as treatments progress, we hardly see these estrogen receptor 1 mutations in the primary tumors. In early on in metastatic breast cancer, in the first line, we hardly see this, just a little bit. But the more lines of anti-estrogen therapy you have, these ESR1 mutations go up. What that means is that if I don't change my strategy with you, the traditional anti-estrogen therapies don't matter because the tumor does not care about that lowering of estrogen levels anymore. It has found a smarter way of going. And so we now have, this is again, one of the benefits of clinical trials. We now have 2 approved drugs that are quite effective when there is an ESR1 mutation. The first one to get approved is elacestrant or Orserdu. And then most recently, just in the last week and a half, we have a second approval for the drug imlunestrant. And then there's a third one in the works as well. Yes, please.
Are those similar to fulvestrant?
Wonderful question. So fulvestrant is an injection. It's given as 2 injections, 1 in each part of the buttocks. It has some activity. It's an estrogen receptor degrader. It has some activity in ESR1 mutated tumors. So thank you for asking that question. But these have more activity in these ESR1 mutations. So depending on the biology of the tumor in that second line, depending on which genomic clone you and your doctor decide is the biggest driver of the tumor, you may use Faslodex in combination with another targeted therapy that I will talk about in a second, or if the disease has been stable for a long time, these are quite well tolerated and they're quite active. So simply switching to an oral pill can quite control the disease. It's not right for every patient and for every tumor. If you had been on that first line targeted therapy for a very short amount of time, particularly less than 12 months, using this single agent approach is not the right one. But we also have many patients who've been stable for a long time and then they need a change and they have that ESR1 alteration. These are quite well tolerated and they're really a wonderful option to have. Yes. Of these? Great question. So none of the studies have looked at sequencing of ESR1 targeted agents. I would say because we have so many other tools, I think rather than sequencing in the absence of data, I would be more likely to recommend another targeted therapy approach or a switch to the antibody drug conjugates that I will talk about in a second. We expect a lot of real world data as we kind of look at some of the sequencing of those SERDs, but I think in the absence of data, I would be a little cautious about giving you something with little data when I have so many other tools that I could recommend to you. So varying toxicity profile, but overall they tend to be relatively well tolerated, so I won't spend too much time on these. Another predominant pathway that we can find in your tumor biopsy or in your blood test is related to what we call PIK3CA or PIK3CA alterations. These are commonly found in over 1/3 of our breast cancers, including those with hormone receptor positive breast cancer. Busy slide, I know, but the most important thing is just again, see it as a rever up. And when it's altered, those control signals that normally keep growth in check are a little more out of control. So these tumor cells tend to grow more rapidly. However, we have very specific drugs that can block these altered tumors, and they've been quite effective. So what I would want to say is that we have a number of trials in the PIK3 pathway. Capivasertib is currently approved, as is alpelisib. These are already the brand names for capivasertib is TrueCap, and for Piqray, alpelisib is Piqray. So these are already approved for PIK3CA altered tumors, but there is a lot of clinical trials about more selective PIK3CA focused agents. And we have 2 big trials in this area. So definitely talk to your doctor and kind of know your PIK3CA. Busy slide, I know, but the takeaway is that if we do find this PIK3CA altered tumors, this is another targeted pathway in addition to the ESR1. Sometimes we have both. This is a question that is debated in every breast medical oncology conference. If you have ESR1 as well as PIK3CA, how you pick among agents. And I would say it all depends. It depends on patient preference, what their disease has done, but it's good to have the options to choose from. Wanted to make sure that kind of back to the additional genomic markers. So if you have those genetically driven tumors, if you have had germline testing yourself showing BRCA1, BRCA2, or PALB2, or if your tumor has one of these changes, so it's not something that you have, but your tumor does, these very selective oral drugs are quite effective, and they're as effective as chemotherapy for patients who have this type of genetic alteration. So just knowing your genetic information, again, is the third important takeaway here. But at some point, and I don't know what that point would be for you, it's unique to the individual, no matter how smart we think we're being with our endocrine therapy and targeted therapies, there will come a time where doing more of these targeted therapies is not the right answer for you. And at that point, we do need to switch gears, and you'll hear your oncologist talking about that. And sometimes it happens a little bit earlier for some patients and sometimes much later. And so the idea is, what if we had a smarter way of delivering chemotherapy? This has sometimes been described as the Trojan horse model, where the idea is we can sneak the chemotherapy into the tumor cells and deliver it where it needs to go. So you're going to hear a little bit more about this in the clinical trial session as well. But the schema in the corner is talking about kind of the principles of antibody drug conjugates, where we find a target, then internalize into the cancer cell, and then deliver the chemotherapy. And there continues to be a rapid growth of these antibody drug conjugates. And here we have all the ones approved in breast cancer currently. I'll talk about HER2, which applies to your group in terms of HER2 low. I will talk about Trodelvy, which also applies to your group in terms of the metastatic triple negative or hormone receptor positive breast cancer. And then we have, just in the last month, we had a new approval of a new agent known as Dato-DXd, and that's another approval that we have. So if this cartoon works, it does? Okay, good. I'm going to show you exactly how antibody drug conjugates work. So for your purposes, it would be if you have that little bit of that HER2 signal, so being HER2 low, so you have your tumor cells, but not all your cancer cells may not have HER2. They don't have to. Just a few of them having that HER2 signal to get the drug in. So the antibody drug conjugate attaches to that little bit of HER2 signal, gets inside the cell, and it's attached. The chemo is attached with a linker, and the linker opens up, and the drug is released. So where it's the orange stuff is the actual chemotherapy. So it's a more elegant way of getting chemotherapy into your tumor cells. And then what about the tumor cells that didn't have the HER2 signal? The chemo actually dissipates to the surrounding cells that don't have the HER2 signal. The medical term for that is called the bystander effect. And the idea is that we are essentially getting at different tumor cells. So although I'm showing this for HER2, this principle applies to all the antibody drug conjugates. So when I talk to you about Trodelvy, it's the same idea, except the target is TROP2, gets inside the cell, and then the chemo is released and is going after those tumor cells. So kind of back to this idea of knowing your HER2 status, I think if you can kind of make sure you know that after you leave this meeting, I think some of you do know it, but I think it's really important. And we talked about how sometimes when it's completely zero, we actually are wondering even whether that's important or not, because the drugs are so good that there might be even activity for zeros. So we have a trial where we are specifically targeting even the HER2 zero tumors with the Enhertu drug. So even if you're zero, you do have an option there. And then this is kind of, again, emphasizing the idea that it's not just HER2. We have other targets like TROP2. TROP2 is another growth antenna. It's present in a lot of breast cancers. Because of its widespreadedness, we're not outside of research doing a TROP2 testing on your tumor. Generally, you're eligible for that. So this is the Trodelvy drug that many of you would be eligible for, and this is an active agent. And so again, kind of the principles of we attach through that TROP2, and then the drug is released, and then the chemo is an analog of an old chemotherapy known as irinotecan, and it gets released. And this was shown to have quite a bit of efficacy in hormone receptor positive tumors, regardless of your HER2 status. So this is definitely an option. And this is our newest drug. It's another TROP2 antibody. So you can see that we do need to get a little bit more creative about our targets, and the field has really recognized that. This is another TROP2, which will set up some active debating within your oncologist brain about, well, can I do another TROP2 antibody if you've had already another TROP2 ADC? So you'll see us debating it, but this is another one that just got approved. And so again, highlighting how just in this fall, we've had at least 2 new agents approved in metastatic breast cancer. One was the imlunestrant that I mentioned, and this one. So I know progress needs to accelerate even more than it is, but this is quite remarkable that this is happening. So a question that keeps coming up is, if you've had one antibody drug conjugate, how will you respond to a second antibody drug conjugate? This is a question that patients ask. It's a question that oncologists ask. And what the data have shown when we look back in time is that that first ADC, the first antibody drug conjugate, tends to have the longest response. But then the second one, your response may or may not be shorter. We're still trying to understand kind of that resistant patterns that happen with antibody drug conjugates. So this is a national trial that is currently ongoing and open at Yale, the Translational Breast Cancer Consortium trial, where depending on whether you start with a HER2 ADC or a TROP2 ADC, once it stops helping you and working for you, then you switch officially on the trial to the other ADC. And the trial is collecting tissue and really trying to understand what is the basis of these tumors developing potential resistance. And this will lead to additional therapeutic options, hopefully in the future. If you're not near Yale breast site, or if, and I know some of you from out of state, the good news here is that all of these agents are also available as part of standard of care. So kind of part of the informed kind of decision-making that we do with all our visits is to say what is only available in clinical trial, what is available in both. And so really, I strongly believe that we need to have these conversations. So if you're not anywhere close to us, I do want to emphasize that these drugs are available and these are part of our tools. But one of our unmet needs is kind of the efficacy of that second ADC and third ADC. I think we do need additional targets and additional payloads. And so that work is going on. This is me just reminding myself to tell you that even if the signal is 0, as part of this clinical trial, we are able to give you that HER2-directed ADC because of the remarkable efficacy of that agent. And we're doing additional testing on archival tumor tissues to understand better which patients seem to benefit more from this approach versus others. Lots of newer agents. So again, kind of back to the idea that we used to only have aromatase inhibitors. This is your Femara, anastrozole, and we have our old SERMs. That's like your tamoxifen, where the idea is tamoxifen binds to the estrogen receptor so that it no longer is able to be activated by estrogen. And then we have our degraders. Thank you for asking the question about Faslodex, where it's our old degrader, where it leaves estrogen levels alone, but is actually breaks down at the receptor level. But then lots of new agents that I think are really opportunities. One is known as a PROTAC, and this was actually presented as a positive study in the American Society of Clinical Oncology just a few months ago. And if you, let me see if my laser works. Yeah, there we go. So these are the PROTACs. So it's a really interesting idea. The idea is let's tag our tumor and then use the body's degradation system to go after what's been tagged. So it's a very elegant way of going after and breaking down the estrogen receptor that also can overcome ESR1 mutation. So I don't believe I put the name of the drug that was presented, but if you want to read about it, it's called Vepdegestrant, and they are going for approval. It's not yet approved. And then there's a whole set of drugs known as serins, which completely block the estrogen receptor in a completely different way. So this is another pathway, and then additional ways of just, again, blocking these estrogen receptor pathways. All of these are currently in the clinical trial setting. So these are not something I can order for you right now outside of a clinical trial, but lots of studies going on, and many of these combinations are available through our phase 1 program. So I think, do want to say that, we used to have these bias, maybe all of us in our heads, that phase 1 programs were, options you would only explore as a very last option, but really phase 1 portfolios have changed quite a bit. So a lot of these newer agents are being tested in combinations with other targeted therapies. So always ask at every juncture, what are my clinical trial options? And this is how we approach it. And it may not be the right time for you for various reasons, but it's something to explore. Yes, please. Okay. Yeah. Yeah. So, sure. So it depends on the stage of the breast cancer. So for what we call non-metastatic breast cancer, the limit of our data with these agents is up to 10 years, where after 10 years, generally we do recommend coming off if there's no evidence of disease. And there are select stage 3 tumors with a lot of nodal burden where some patients and their oncologists may choose to go a little bit more. But in the metastatic breast cancer setting, if a drug is working for you, we keep going. So it's very much stage dependent. In the setting of advanced cancer, we're typically not recommending taking you off of a therapy if it's working. So if it was more of an early stage breast cancer, then up to 10 years is generally the recommendation. So I think in these complicated situations, I think it's really important. It's back to that shared decision-making where, patients may not classically fit into the way the clinical trial eligibilities were, like anytime there's been 2 breast cancers or other nuances. I think it's really important to have a discussion about the pros and cons. What does it mean on your body if you go a little bit longer? Are there other complications that could happen? I think there have been situations, I just had a similar patient where she really felt strongly about going longer, and I chose to honor that because I think it's about a discussion. Yes, please. Yes. Yeah.
But are they thinking it's better than just the
Yes. So the latest that was presented in the American Society of Oncology with Vepdegestrant was that the activity was most pronounced in ESR1 mutations. And although FDA regulatory submissions are, I'm not privy to them, likely they will be focusing on those ESR1 altered tumors. Yes, so that's where the activity was the most. There was actually not that much difference between fulvestrant versus vepdegestrant in non-altered ESR1 tumors. Yes. Yes, yes. So that would be an that would be an older SERD, which let's see, SERD. So the idea is it's some type of a degrader. So it's actually breaking it down. Yes, so breaking down the estrogen receptor. It has modest activity. It's a great drug. We typically are using it not as a single agent anymore. When it's tested as a single agent, it's often beat out by many of these newer agents. But in combination with drugs like capivasertib, alpelisib, other CDK4/6 inhibitors, fulvestrant is a drug that we actively use. I will say in general, I mean, there are always exceptions, but kind of saving Faslodex use for that second line setting is more often prepared because then we can combine it with other partners. So not always starting with Faslodex on the same first line is generally preferred. So yeah, but it would fall under that selective estrogen receptor degrader, yes.
You mentioned that.
Yes.
But what are the actionable next steps?
Ki-67 is interesting in that there can be tremendous variability there, depending on which lab and which pathologist. So it's a measure of just how actively proliferative your tumor cells are. Some labs are running it, some are not. It can be a way of distinguishing a more hormonally driven tumor in that luminal A type subtype, compared to if you're seeing a very high Ki-67, you're going to think it's more likely to be that luminal B. Maybe it's going to be less responsive to our endocrine therapy targeted therapies. So I wouldn't necessarily, if somebody with a higher Ki-67, I wouldn't necessarily not offer them endocrine therapy targeted therapy because I think it's not the most reliable test. However, it's part of that information, but I would probably maybe have that conversation with the patient that maybe the endocrine therapy approach may not work as long as maybe what we see on average. If it looks like it's not helping us, we can always switch very quickly to some of our antibody drug conjugates or something else. So but it's not universally done in every path report, depending on the labs. You can always ask for it. If we feel like we need that information, it can always be asked for.
So a higher number is more.
Higher number tends to be more of a proliferative tumor type that is more likely to respond to antibody drug conjugates or traditional chemotherapy, and tends to have shorter endocrine therapy sensitivity. Another measure of endocrine sensitivity is actually looking at your ER percentages. You know, we've kind of grouped you all together into hormone receptor positive subtype, but there's quite a bit of variation. So there are patients that may have only 10% positivity. Some may have 50% positivity. Others may have 99%. So just how high that percentage is another kind of rough estimate of potential responsiveness. Another clinical measure that we use in terms of how responsive you'll be to future endocrine therapy is just how long your previous endocrine therapy response was. If you were on it for years and years and years, then that second line of therapy is likely to be longer as well. Usually we roughly estimate the rule of halves. So if you were on your first line therapy for 3 to 4 years, then second line is approximately at half. These are all estimates. But your previous response to endocrine therapy is a big, important predictor of endocrine sensitivity. Lots of new targets are being looked at, including HER3. So this is the HER family, HER1 or EGFR, HER2, HER3, and HER4. There's been a lot of new research in this HER3 pathway. And we actually have a drug for this. This is another antibody drug conjugate known as HER3-DXd. This is only available in clinical trials, but same idea of we're using a target, using it to get inside the tumor cells, and then releasing the chemo. And so this was shown to be reasonable, to have reasonable efficacy in patients with hormone receptor positive breast cancer who had had several lines of prior chemotherapy. Not available, it's not something that I can order for you outside of a clinical trial, but did want to emphasize that this is another targetable pathway that a lot of research is going to be devoted to. In terms of trials that we currently have additionally at Yale for your subtype of breast cancer, nectin is another surface protein. I've talked to a few of you here on this. So even while you're on a stable line of therapy, you can actually ask your doctor to test your archival tissue for eligibility for this nectin protein. And if you're positive, then at the time that you need a next line of therapy, we could potentially offer this nectin antibody drug conjugate. So again, the theme is we want to understand your tumor, know what the targets are, and then we typically have additional therapies. Spent some time, the second bullet is focusing on, we talked about the cyclin inhibitors, the Ibrances and the Verzenio's, but through dedicated research, just focusing on one part of the pathway with very selective cyclin inhibitors. They may be CDK4 only inhibitors or cyclin D6 inhibitors, and there's even work with cyclin DK2 inhibitors. So they are showing to be quite promising, and we do have several of these available in our phase 1 program. So again, just I think at every opportunity, asking your doctor if there is a targeted therapy option available, so you know all your options. Cell-based therapy, we do have one trial that is using immunotherapy. What I haven't touched on till now is, in general, immunotherapy for hormone receptor positive metastatic breast cancer has not been the most promising approach so far. So there's a lot of immunotherapy used in triple negative breast cancer, but we're beginning to learn that there may be subsets of hormone receptor positive breast cancer that may also benefit from an immunotherapy approach. So there is a cell-based therapy, immunotherapy option for potentially eligible patients with hormone receptor positive metastatic breast cancer. It's actually open to all subtypes of breast cancer, but hormone receptor positive is eligible. So we're doing this through our cell-based therapy program. So the way I position this option for my patients is after you have tried that first antibody drug conjugate, where we're just beginning to learn how to optimally sequence future ADCs. This might be a good option potentially to think about sandwiching there as a more research-based options. And then lots of phase 1 trial options. Your doctor can directly message us in the phase 1 program. Dr. Adriana Khan, who's currently speaking on the HER2 positive session, can do a virtual visit with you, review all your phase 1 options, so you don't have to travel to New Haven to have your phase 1 options reviewed. So we're trying to make it as easy as possible for you to do that. So I think we strongly believe that clinical trials should be viewed at every juncture as a complementary option. I think how we select among these agents, this is my last slide, and I want to open it up to more questions, is we really kind of back to how endocrine sensitive your tumor is, or do we need to switch gears to antibody drug conjugates? I think that's like a big, important question that we ask ourselves, and try to really explain that to you as we're seeing you in these sequences. So if some of you have seen me in clinic, where I say, yes, you do have endocrine therapy option, but I just don't think it's the right option for you at this time, given what your tumor biology has shown me so far. So these are some of the discussions that we have. Let me take questions or comments, or yes, please. Yes. Yes, great question. So the traditional approach in metastatic breast cancer is some type of body scans, one. So it could be CAT scans or PET CT, either or. And also the second is how you're feeling. So generally when our treatment is working, you feel good. You may have some side effects, but generally when metastatic breast cancer is under good control, quality of life is also good. So asking you in visits, how are your symptoms? Do you have new things that you're worried about, are a big part of it? The third piece that may or may not be used is sometimes we use blood-based biomarkers such as tumor markers or circulating tumor DNA. I do want to say for those of you not with metastatic breast cancer in the audience, those blood-based biomarkers have not been shown to be helpful in non-metastatic breast cancer, so we do not recommend them. But in the metastatic setting, particularly with patients who may have, let's say, bone-only disease, it can be really hard to follow bone changes on scans. Sometimes as they heal, they actually can flare up or look bigger. So sometimes those blood tests can be additionally confirming that, gosh, we're going in the right direction. Yes, yes.
Whenever I have that blood test done, those cancer
Yes.
markers, it's always proven that I'm going well.
Yes.
And then when I go to the PET scan, I have a tumor. So for me, that test, and I tell my oncologist all the time, I just can't go.
Completely agree. So I think it really depends on whether your tumor type is actually shedding the type of protein that's measured in those tumor markers. And for certain tumor types, it can be very inexact, which is why tumor markers should not be used by themselves. There is a clinical trial that's asking the question, but apart from that, as part of routine practice, really scans and how you're feeling is the most definitive. I saw a hand somewhere. Yes.
About these genetic changes.
Yes.
And from a basic blood test can test for like HR2, but you said some of the cancers themselves can have genetic changes, but those aren't going to show up in a blood test, right?
Great question. Okay, so good. Yes, yes. So the most reliable test currently, although there's a qualifier there because the blood tests continue to improve, the most reliable test for HER2 low status or HER2 status remains actual tumor tissue. There is work being done in this area about somehow using the blood so you don't have to go through an uncomfortable biopsy and all that, but great clarifying question, which is that for HER2 status, tumor tissue is the gold standard. But the other genomic alterations like ESR1, PIK3CA, particularly ESR1, what studies have shown is that the blood test may actually be a better test. These are dynamic clones. They are acquired resistant biomarkers. So there was actually a study called Plasma Match, which compared our success of finding ESR1 alteration in the tumor versus the blood, and the blood was actually a better capture of those clones. So I think based on your question, I would say generally most of the biomarkers can be found reliably through our circulating tumor DNA assays, which are available through a number of commercial companies. There's not just one. But for HER2, if there's any question about the HER2 status, the tumor tissue testing and actual tissue is the gold standard.
Beyond HR2, the other genetic changes, is that something that you find like in an old biopsy that you know more about some of these genetic changes? You don't have to do a new biopsy, can you get that from an old biopsy?
Great question. Yes, except for ESR1. ESR1 is a dynamic biomarker. If your doctor went back your tumor tissue from 2 years ago or 5 years ago, it may not have been there. So it's really important for the purposes of ESR1 alterations that a new biopsy, either a liquid biopsy or a tumor tissue biopsy is done, or we could miss it.
That could be done within the metastasized area, it's at home.
Or just a blood test, would capture. A blood test would be a more reliable test for ESR1 alteration. And you can absolutely ask your doctor about that. Yes.
I had, when I got diagnosed in 2021, in July, I just had, and in October, I got diagnosed with stage. I went on iron, and then that caused an ulcer. I couldn't breathe.
Oh, so sorry.
So I had to get off. Then I went on to Receptor, and I just had to be off of Receptor. But because it became toxic, I mean, I lost 20 pounds in like 3 weeks. It was just awful. I couldn't get out of bed. I couldn't go anywhere because I had no quality of life. It was, if I even took a sip of water, I had to look for exits to the bathroom because I couldn't even make it to the bathroom. My question is, my oncologist, I had progression the entire time while on Receptor. I had 3 tumors pop up. Now I just have one on my spine. But he makes it seem like, they're not that big. They're not that big of a deal. So my thing, should I be questioning him? Like, can we test my new tumors? Because one of them did show that it genetically changed. Like, I was HR positive, HER2 negative, but that one showed it was different.
I think taking another look, I mean, without knowing all the details, but what you're describing, I think I would say I would definitely want to make sure you've had some type of sequencing. So we know the genomics of that are currently present, that are the most active clones. So either sequencing the new tumor biopsy or even a liquid biopsy, I think would be important. And if you had not shown evidence of progression, I would just make sure that lower doses of Verzenio had been looked at. Okay. I'm sorry that it was such a hard experience. Yeah. So I think you do have a number of options. I think asking the question is never wrong. And so the way I would approach your particular situation is I just need to understand the biology of your tumor. And I think there's a number of choices that we could choose from depending on what that shows. So it depending on how long the intervals of progression were, this may be an opportunity to do more targeted therapy, or this may be a time that we might switch to traditional chemotherapy or an antibody drug conjugate. No, so thank you for asking those questions. So chemo is a tool. So it has different uses at different settings. In the setting of metastatic breast cancer, it's absolutely a tool that we use, particularly when the targeted therapies are not helping you. So it's one of our tools, and it could be chemotherapy, it could be antibody drug conjugate, and absolutely what studies have shown is that when used in the right way, it can control the disease, improve quality of life. So absolutely, it's not an option that's excluded. It's one of our tools. Happy to talk to you offline, but I think you have a number of options, but I'm truly sorry that you have had such a hard experience. One last question. We're at time, but happy to, yes, please. Sure. Okay.
You have nothing to worry about. But I'm of that group that says with DCI, so I not treated.
Great.
So now is it appropriate for me to say to myself, I would like some line memory? Does any of this information I'm taking that one away.
Yes, so in the setting of DCIS that was treated for 5 years with endocrine therapy, but no surgery or radiation. I think there is a study that has looked at that. Yes, the COMET study, yes. What we do after 5 years, I think has to be individualized. So I think it's a great question. And I think it depends on what your imaging is showing, what your toxicities are, but probably I would say we have limited data about going beyond 5 years in that setting, but I would have to see kind of more of your DCIS characteristics. It's a great question. And as the COMET data continue to mature, we should have also more information on that as well. So it's a great question, and thank you for being here. But in terms of giving you additional targeted therapies that are more approved in the metastatic setting, that would be truly not in your best interest for your particular type. Thank you, everyone. Oh, I can, yeah.
Really quick question, is Fluffy basically the same medication like Ibrance?
They are in the same family of those CDK4/6 inhibitors. They have overall, all 3 agents have been associated with improved progression-free survival. Kisqali is actually the one that's been shown to have an actual overall survival advantage in the landmark study. So I would say, since you have tried 2 different CDK4/6 inhibitors, I would say trying a 3rd agent may or may not be the right approach. I think it will depend on some of the biological biomarkers, but I think they're in the same class. Thank you.